Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast. Welcome to the podcast. We have Luke here and we have Giles. How are you doing, lads?
Good,
man. Great.
So it's early morning in Brisbane. It's about 10 here in New Zealand, and it's 10 o'clock at night where you are, Giles, in London. Is that correct?
About nine o'clock at night, so it's nearly bedtime.
Okay, so today we're going to be talking about unethical X-rays, and this is actually going to be based on an article, a peer-reviewed published article that's up on PubMed right now that was authored by myself, Luke, and some colleagues, and then a version of that article is going to be in the upcoming book, OMT book, which is on chiropractic techniques. So I'm looking forward to everybody getting their hands on that, all two of them. Giles' mum. No, three. Giles, Luke, and yeah.
It's a great. It's a stocking filler for fun for all the family.
So, so yeah, we're going to be talking about X-rays, and I just want to start off this episode by saying that we're not against X-rays across the board. There's context here, so please listen up. I hope everyone gets something out of this podcast, but we're not sitting here saying that X-rays should not be used. They absolutely should be, and we're going to very carefully and specifically go through when and how they should be used, and we're going to also discuss sometimes when they shouldn't be. So like I said, there's an article out there. I'll put it in the show notes. Make sure you do read the source material if you have any questions, and engage in the comment section. Anyway, so let's get into the podcast. So chiropractors often use radiological imaging, so particularly X-rays here, to diagnose pain. This approach is flawed, in my opinion, or our opinion, as you're going to hear, because X-rays will provide often anatomical information with very little contextual or functional information. Pain, tissue damage, and injury obviously do not always correlate with X-ray findings. Many asymptomatic patients show structural abnormalities with no pain, right? Structural changes with no pain. We'll get into that. And then we have key concerns over overdiagnosis, misleading patients about the cause of their pain. There's obviously no proven link between pain and reverse cervical curves, which is often talked about with chiropractors. And then there's variability in X-ray accuracy due to positioning, reliability, and the patient's state. And medical boards and health associations obviously discourage routine use of X-rays for non-red flag cases. So a brief bird's eye overview there of a few thoughts, and we're going to go through and get into the nitty-gritty. A lot of what we're going to be talking about here does apply to various professions, but one profession seems to do it a lot, and that's chiropractors. For those that don't know, I met Luke at chiropractic school. I left halfway through my fourth year. Luke went on and did obviously his fifth year, graduated. He's a chiropractor. I went and did exercise physiology in my PhD. And now what we talked about in chiropractic school, our brand and what we wanted to do, we're now doing. And so we're in business together with the rehab professionals. I was around long enough to spend long hours in the X-ray suite in the dark room with Luke, drawing up lines, reverse curves and cervical curves, and making these big red lines to show to our patients so that they, feel a certain way about what they're seeing. You show them these X-rays, which seem very diagnostic and medical, and you have these lines on them, and you're telling them what should be normal and that what they have is abnormal, and you get this very hyper emotional response, and obviously they want to continue care. It's a real ethical dilemma, and that's why we're passionate to talk about it. That's why me and Luke have published on it. That's why it's going to be in this book with Giles and the OMT team, because we're passionate about it. So we're going to start off with the diagnostic validity of X-rays. And I touched on this a little bit before, but pain, tissue damage, and injury do not always correlate with X-ray abnormalities. And I actually discussed this recently on our Instagram page, where I talked about structural abnormalities or structural changes not equaling pain or necessarily even pathology. And that's something you have to be aware of as a rehab professional. Many pain-free individuals have the same structural abnormalities seen in symptomatic patients. So if I went to the mall and I said, hey, I'll give 10 people $100, a line up on the wall, and I want an X-ray or MRI you, and then I want to ask you some questions, you're going to have changes in most of those people, and most of them are going to be pain-free. So that's a really concerning statistic or understanding of how we need to use imaging, that we have to have these comprehensive histories, assessments, and understanding of the person that's sitting in front of us to come to what would be a proper diagnosis, and not just looking at scans. Anyway, I digress. There are some key studies that do touch on this. Huru ECL 2003 showed that out of 75 detected bone injuries, only 30 were symptomatic. In 2020, there's a study of 150 asymptomatic adults, so they had no pain. And they found that 97% had knee abnormalities. And I'm talking tears, ruptures, cartilage, lesions, etc. 2015 systematic review, over 3,000 asymptomatic individuals showed up to 96% disc degeneration, up to 84% disc bulge, up to 83% facet degeneration, up to 50% spondylolisthesis, all pain-free. So when we look at some guidelines and statistics, the European and US guidelines actually discourage routine x-rays for lower back pain without red flags. And we're going to go into a little bit more about that later. However, a few interesting stats that we need to know, especially when we're dealing with lower back patients. Serious pathology is only found in 0.2 to 3.1%. Fractures, 0.2 to 6%. And these negative outcomes of premature x-rays, so just doing routine x-rays, which could be number one, you've just jumped the gun, or number two, you're following a protocol that you're being taught and you're using it as a way to find a misalignment, like a vertebral misalignment or a subluxation, or you're actually using it as a way to get more clients. Once you get a client through the door, you're using it as a way to kind of retain clients. So you're showing them these x-rays. They seem very diagnostic and medical again. And then you're saying, okay, we want you to come in every week, 3 to 4 times a week for the next 20 weeks. And then you put them on a wellness plan. This is all in the show notes in the study. Go through and look at all the references. Make sure you read it yourself. So often when people come in, obviously they have a complaint, and patients are often very emotionally charged because they're going through a hard time and they are dealing with a pain, a musculoskeletal pain. They're obviously concerned, and then they will go to a chiropractor, and the chiropractor will begin to talk to them about how their posture is all wrong, how they're standing wrong, they're moving wrong, and then they'll x-ray them and show them that all their vertebrae are wrong. So, Luke, could you talk to us a little bit more about the relationship between posture and pain?
Yeah, so as you touched on before, there are many clinicians, particularly chiropractors, that are using these types of imaging x-rays to justify treatment for patients by highlighting certain postural changes that they may have, often implying that these structural changes are the root cause of the patient's pain or symptoms, essentially. It raises massive ethical concerns with this, as patients may be misled to believing that their x-ray findings directly correlate with their pain and symptoms, potentially leading to unnecessary fear and reliance on prolonged treatment plans throughout their care. So when it comes to a lot of the research, it's pretty much telling us that there's no correlation between pain and structural changes within the spine. Reverse cervical curves, lordotic curvatures. Most of the research, if not all, between a lot of the studies that I have on here. First one is saying 2016 is there's no difference between injured and non-injured participants in spinal curvature. So that's a tick there. A massive systematic review found no link between postural curvatures and overall health. 2003 study found no correlation between reverse lumbar lordosis and pain. A 2014 study that had 762 participants found no link between sagittal cervical alignment and neck symptoms. And a 2015 study with 983 cervical x-rays compared asymptomatic individuals with acute whiplash patients and found no significant change in cervical lordosis. So a lot of the research that we've looked at within this article and paper is backing a lot of what we're saying, is there's not necessarily a correlation between what the patient has on imaging and what they're sort of presenting with in the office.
Yeah, and we have to consider, what are we comparing it against? So there's a baseline, right? Like, what is normal? Because we talked about Friart's Law and Punjabi, and we were talking like, okay, we are telling patients that something's abnormal based on what we're feeling. What is normal is based on this belief system, this ideology, this philosophy, this system, this protocol of what is normal, Punjabi, Friart's Law, how do vertebrae move. And what we thought was our baseline to be our accurate baseline of which we would compare things against so that we could have a diagnosis, ended up being not very accurate at all, because all the other research was showing heterogeneous results or varying results, right? So similar thing when it comes to x-rays. If we take a step back, okay, pain and posture, not necessarily related. Now, we fully understand that when people are coming to see us, they're symptomatic. If someone's symptomatic and their neck's hurting, we're going to assess the neck. Look, so many people straw man this part of the argument. Yes, we're seeing people that are symptomatic. If they have a fucking sore neck, we're going to look at the neck, and then we may look at other areas if we need to, right? Functional testing, etc., etc. So we acknowledge that the clinical environment is always going to be a little bit different than the research, but this research is giving us a broad overview because we can't come to these conclusions without thinking for ourselves, without looking at the patient for ourselves. And when we do, and we think of accuracy, what are we comparing it to? So we're comparing it to the x-ray. Is the x-ray even accurate? And the answer to that question is likely not. I'm going to go through some really good points here, but let me first say personal experience. Me and Luke did our practical. We did 6 X-ray classes, and I think I might have done 5 of those or 4 of those. But we started with like basic radiology, and then we looked into what would be practical, like how to actually do the X-ray on people. Then we had to do a rotation, an X-ray rotation, so doing it for the patients. And then we had a diagnostic imaging class that was separate where we learned fractures and pathologies. But me and Luke, man, we put hands on patients. We put hands on X-ray machine. We, monkey see, monkey do. We move machine. We take image. So you feel like you're doing sometimes because it's not accurate. You're literally moving the patient's shoulder. I'm looking at Luke. I'm like, you got that? Luke's like, no. I'm like, yank. I'm like, hey, we're going to try this. Okay, can you just move your head this way? Patient's like, oh, like this? I'm like, yeah. And then I'm like, okay, no, move your head back a little bit more. The image is completely changing every time you move that human in front of you, right? And it almost becomes a joke because even as a student, me and Luke are looking at each other going, like, we're changing the out. Every time we tell this person to move, we're changing the results. And now the chiropractor on the other end, looking at the X-ray that we took, is going to draw up lines and tell their patient that there's something wrong with them, and that's going to justify treatment. Me and Luke will come out of that class being like, this is not right. Hence why we publish research on it. The accuracy of X-ray measurements, patient positioning, questionable. It changes. How does it change? Physical or morphological changes, doctor interreliability, depending on how they're doing the setup, what type of machine they're using, the quality of the machine, where they're putting the person in relation to the bucky, all this stuff changes it. External factors, stress, hydration, sleep, prior activity. Did they train? Are they hydrated? Do they sleep well? This changes how we stand, okay? Even how we feel, our emotional state, anxious, depressed, confused, anything, how we feel changes our positioning. This can change what comes up on the X-ray. Now, people will say, no, we have very strict protocol. No, you don't. No, you don't. We got very strict protocols. We do our leg length. End of the day, you moving that patient around like a bowling ball, okay? Like it's ping pong season, okay? I've seen it. I've done it. You're doing whatever you got to do to get the image. At the end of the day, we have verifiable data that shows that it's not consistent. For example, there's a study that shows a 5-degree Cobb angle difference when radiographs were taken at different times of day. From memory, I think that was morning and night. 2001, Triano ETL also concluded spinal X-rays to be a poor method for detecting specific areas requiring spinal manipulation. Of course, we should not be using diagnostic imaging to find vertebral misalignments, musculoskeletal misalignments, or subluxations. It's not appropriate. It's ethically questionable. And we're going to go through the actual guidelines and what is required of us as professionals. And it's not this. Okay. Luke, take us through the chiropractic vertebral subluxation.
I'm going to keep it relatively short and brief, just to not overly confuse the listeners. But there's two terms we're looking at. One is the chiropractic subluxation, and one is the medical subluxation. So the traditional chiropractic concept of vertebral subluxation suggests that misalignments of the spine essentially put pressure on nerves, disrupting the so-called mental impulse and even contributing to organ disease. However, the idea of this differs significantly from the medical definition of a subluxation, which refers to a partial dislocation of a joint that is visible on something like imaging and is often associated with trauma or ligamentous instability, whatever. Scientifically, we know that bones do not simply slip out of place to compress nerves in a way that cause disease. And there is no proof of that mental impulse, that interference exists. When we're in chiropractic college, we were just told that it exists. It's not something physical that can be objectively measured. As a result, these X-rays should not be used solely to diagnose or justify treatment based on this outdated theory. Now, in response to a lot of this growing scientific literature, there are different groups that have sort of come together and essentially moved away from the traditional chiropractic theory of a subluxation. One of these groups that we were taught in college is by the name of the Rubicon Group. And what they have done is essentially redefined subluxation as a self-perpetuating segmental motor control problem affecting neural plasticity, moving away from that traditional nerve pressure model. To put it simply, we're moving away from bones being out of place, nerves being impacted, to something that affects the brain and nervous system overall. So to take into these sort of both of these definitions, it's important to consider, I guess, where it's sort of come from in the past and where it's moving now, and just to put aside your own bias from it and take what you need.
Yeah, and it's good that we're moving on from a bone out of place. It's good that we're moving on from this kind of subluxation model being so structural. However, it doesn't mean the new model is correct either. It's just that's not the topic of this discussion nor this podcast. But the self-perpetuating segmental motor control problem affecting neuroplasticity is not necessarily accurate either. However, it's good to be moving away from the structural bone out of place model, which is ridiculous.
Well, there's a couple of points you made earlier. One about looking for the perfect or the normal positioning of the patient or the normal joint. I don't know what normal is. I don't think I've ever seen normal. So I think you're chasing a dream, like this biomechanical perfection. So when you're looking at an image, to tell that image, to say to that person that that image is the cause of their problem, you would have to have seen them 6 months, 12 months earlier when they were completely pain-free, and imaged them then to then be able to validate the modern image. So it always baffled me. So it's saying to the patient, you know, you're poking the patient, oh yeah, your problem is L4. And I'm like, well, I should have seen you a year earlier when you were completely pain-free and had a good look at L4 to really be able to give you that sort of diagnosis. I just think it can be incredibly misinterpreted by therapists using it as validity to treat. And, you know, they say bullshit baffles brains. You know, that definition of subluxation, you know, you compile together a long list of incredibly medical sounding words, and it does sound very professional. Waving an X-ray in someone's face does sound very, very professional, very medical, and actually quite scary, especially if the patient is vulnerable and fearful and in pain and in discomfort and in emotional stress. And you go, look at this, 7 sessions a week for the rest of your life, and you pay what you pay. It's a problem. So as an osteopath, like I got trained in, so as an osteopath, we can refer for imaging. So we have been trained to refer for imaging. We do not take imaging. We do not take X-rays. We interpret X-rays. We can read X-rays, and we can refer for X-rays. But there was never, and as far as I'm aware, having worked across many, many universities across osteopathy, there is no program where they will teach you to take an X-ray, especially for diagnosis of an MSK condition. It just is not done. Same in physiotherapy, and actually in the UK with chiropractic education, again, it's not something that's commonplace, to be honest. So in our country, for example, yes, I can interpret an X-ray, but predominantly I am referring for an X-ray because I believe there is a problem. Go away. So if I'm thinking, Jesus, we need an X-ray, that patient should not be in my treatment room. They need to go. Do you know what I mean? For safety considerations, this is just common sense. For God's sakes, when I go to the dentist and they want to X-ray my teeth, they run out the room and down the freaking corridor. You should not be doing routine X-rays if you don't need it. The exposure, the radiation, there are significant health risks. You know, crikey, I just think overuse of things like X-rays can lead the patient down the garden path and create massive amounts of confusion. Also, overdiagnosis. So you'll take an image of someone and go, right, that's it. That's your problem right there. But that might actually not be the problem whatsoever. That might be something way down the line. It could be something completely irrelevant. And if you're relying on your diagnosis by one method, then you're flawed because it's about multiple things. I mean, we said case history last week was the most important thing. Yes, it is. But if you're shit at case history, if you're shit at clinical thought process, if you're shit at being a decent therapist, tell you what, take an X-ray, blame it on that. Because it's an easy way to switch off your brain. A bit like when the therapist says, well, I don't need to clinically think, I can just use ChatGPT for my diagnosis. All right? Idioto, right? Absolute freaking numpties. It's about a collective thought process. Common sense. So for me, repeated X-rays can cause overdiagnosis. It can cause inappropriate treatment advice, inappropriate treatment for the patient. You know, and I think people can ultimately cause more problems than they're fixing. So in a nutshell, common sense. If you do believe the patient needs an X-ray, refer them out.
Yeah, and then moving on to that unethical communication and fear-mongering overall, as I touched on before, chiropractors are using these spinal X-rays to highlight benign findings that we find on imaging, such as osteophytes, disc height reduction, spondylolisthesis, and in certain transitional segments, to essentially convince these patients that they have serious spinal issues and require excessive treatment plans. What this approach does is it often relies on fear-mongering, particularly through misleading claims about what we call and what we were taught so-called degeneration phases. So a lot of them within the clinic will have, 3 or 4 images of spines up on the wall, phase 1, phase 2, phase 3, phase 4, and they compare your spinal imaging and put you into a certain category that dictates what treatment plan you follow and essentially, how messed up you are.
Sorry, Luke, is it a bit like those drug pictures? Jimmy before crack, Jimmy after crack. No teeth, like this. It's like the before and after of those "don't do drugs, kids" pictures.
That's exactly it. Yeah, they're images on the wall, or we even had models, Brogan. So we'd have like 4 spinal, like 3D models. So like, the clinician can bend your spine in a certain way and show you that it doesn't move, etc. However, there was an interesting study done in 2015, and it found that disc degeneration is present in 37% of 20-year-olds and 96% in 80-year-olds. So essentially, the older we get, the more degeneration, the more benign findings we're going to have on your X-ray, demonstrating that these changes are a normal part of aging rather than a direct cause of pain. So scare tactics like these can have extremely harmful consequences, and we've seen it. I've seen it with my own patients, as research suggests that they contribute to fear avoidance behaviors. So moving differently overall can reduce self-efficacy and may even increase the risk of long-term chronic pain.
Yeah. So the other thing to consider, I'll put up on the screen the phases of degeneration so that people watching this can get an understanding of what we're talking about. It's also important to recognize that, especially when it comes to the discs, for example, 70%, when you look at twin studies, so there's there's a few really good twin studies out there, and 70% is genetic. So a lot of this degeneration that's occurring is genetic. And of course, we want to be optimistic in our approach when it comes to lifestyle factors, overall health, exercise interventions, that we can help prolong these structures, or we can do these exercise interventions that can potentially improve the health of such structures. But we do need to understand that we can't use these degeneration models as a scare tactic and say to somebody, if I adjust you, this is not going to happen, because it's likely going to happen based on the genetic time code, or depending on other lifestyle factors that you're not even talking about as a chiropractor.
But you can't predict the future either. This was this discussion I had with a therapist the other day, going, they were saying to their patient, "Oh yeah, but the way you're holding yourself, you're going to be in pain in 5 years' time. You're going to," and I'm like, if you know that, give me the lottery numbers for the Euro Millions. Give me the lottery numbers, because you are Nostradamus. You are able to predict the future. It's absolute nonsense, the idea that someone is going to definitely be in discomfort and pain, and that you can predict that. I think it really is a slippery slope for patients and therapists, causing more problems than solutions.
Well, the radiographic findings, or the X-rays, they're not a crystal ball. They're not mirror on the wall. They're not something that you can look into and tell the future. So we need to be very careful with our clinical communication around those things. Right now, I'm going to put an image on the screen of a cervical spine. So let's say like a lateral cervical view. So you can see the occiput, you can see a little bit of the jaw, then you've got your cervical curve. So I'm going to put that up on right now. I'm going to put it up. You can see that there are some lines. There are 2 red lines indicating that this cervical curve has reduced, right? Unfortunately, this is what we see. We see kind of these chiropractors use X-rays as a way to kind of fabricate positive treatment results or scare patients into signing up for more treatment. They draw up these bright lines to show postural changes, such as these kind of reverse curves, kind of convincing the patient that this is directly responsible for their dysfunction and pain. And that's what's unethical about it. Not only is this super unethical, right? But it's not even backed by research at all, kind of what we've touched on. What I'm going to do now is I'm going to put up a second image. And this image, the spine is now being corrected, okay? And there's a nice tick, and the lines are not red anymore. They're yellow or green, and they're showing the cervical curve. Here's the kicker. Both x-rays I showed you are the exact same image. I simply ruled up the lines differently, fudging the results to suit a narrative that is good for my wallet, but not necessarily good for you as the patient. And that should give you a little bit of an idea of how you can't necessarily trust somebody ruling up lines and telling you that you've got pathology or the reason for your pain or reverse curves or misalignments or subluxations, and they're using these fancy drawings and they're like, run out of the office if you see that. And if you think that I'm straw manning the other side, like I'm kind of making up an argument to attack it down, that's certainly not the case, right, Luke? We've done this, haven't we? We've drawn up these images and we've had these conversations, and it's very difficult.
So, yeah, current imaging guidelines is different guidelines for different parts of the world. The American Board of Internal Medicine's Choosing Wisely initiative advises against imaging for musculoskeletal pain unless clear red flags are present. So, to put it simply, nothing other than red flags they're using imaging for. Similarly, non-specific low back pain, although we hate the term, guidelines are recommended conservative care for up to 6 weeks before considering any sort of imaging, with both Australian and US guidelines discouraging routine scans. Then when it comes to in trauma cases, the Canadian C-spine rule, cervical spine rule, provides clear criteria for when imaging is necessary, limiting it to cases only involving individuals over 65 who have high risk injury mechanisms, potentially any sorts of neurological deficits or some sort of known pre-existing spinal disease. All these guidelines are doing are essentially highlighting to us the importance of evidence-based decision-making in imaging and ensuring that patients are not exposed to unnecessary radiation or fear-induced diagnoses, essentially.
Look, to be fair, guys, this is bread and butter stuff. This is like common sense. I mean, ultimately, if you think someone needs a freaking x-ray, it's probably because you're suspecting some form of fracture or they've had significant trauma. They shouldn't be in your room anyway. The only reason why I would be looking to refer for an x-ray is if I believe there was some type of red flag for some form of bone issue or joint issue, like a fracture, for example. Absolutely. Then refer them out. But that's the only reason why I would be using or suggesting x-rays. Predominantly, we're going to be referring for MRIs because for more soft tissue type things. And again, then it is common sense. You don't MRI people every single time they come in with a freaking problem, just like you don't x-ray them. If they are presenting with significant red flags or enough red flags that you think risk versus reward, remember, no one's ever going to criticize you for being cautious. As a cautious practitioner, no problems with that at all. It's when you just smash people without thinking there's a problem. But things like, for me, keep it simple, right? Keep it simple. If the patient is presenting with things like bilateral pain down both arms, pain down both legs, yes, it could be MSK, but it could be something significantly problematic. I would probably be referring. If the patient had saddle anesthesia, loss of bowel and bladder controls, cauda equina type symptoms, I'm going to refer them out for some form of image. If things are progressively getting worse after a couple of treatments and I'm not sure, then I'm probably going to refer them to a GP for further imaging or testing or whatever it is I think is appropriate. The only time you should be kicking people out your door is if you believe that they're not safe to treat or there's something outside of your skill set. Remember, you are there to help the patient and to look after the patient, which means, great case history, good case history, and only referring them out to imagery if you believe that there is a red flag. But like I said, common sense should really be playing part of it. Unfortunately, common sense doesn't always tend to be in the clinical room a lot of the time. But the things that you should be hands off for, maybe consider referring out.
Yeah, you're right. And like you said, it's ABCs, isn't it? We learnt this stuff pretty early on, and
but we forget the basics, don't we? We forget the basics and we get lazy. And actually, the older I got in clinical practice, the lazier I became with my case history. And unfortunately, it wasn't until about 7 or 8 years ago, we had a significant problem in our clinic when one of our patients, unfortunately, had an issue that they ended up having to seek significant medical help for. I always think about that incident because they were seen by a new graduate. But when our notes were taken, we were able to show that really good case history was done and the patient was referred. When I look back at that as a senior therapist, common things happen commonly. My ego was up here. I probably would have treated the patient and I would then have probably not be an osteopath today. So this is why it's so important. You don't rely on one image. You have to be doing as thorough case history as when you graduated, as when you are 10 years down, 20 years down, 30 years down, because familiarity breeds contempt. And if you're not asking the right questions, if you're not thinking outside the box, if you're not thinking clinically, and all you're doing is relying on an image that could ultimately be wrong anyway, then you are putting yourself in a very precarious position. So think, for God's sakes, think before you put your hands on people, and always think, is this appropriate?
Hey, that was a great way of wrapping up. We're going to finish it there. I'll go through and I'll conclude a couple of points and then we'll end. So obviously x-rays are essential for diagnosing serious conditions. We're not saying they're not, but shouldn't be used for routine postural misalignments. Research shows no clear link between spinal alignment and pain. Overuse of x-rays can lead to overdiagnosis, unnecessary treatments, and increased radiation exposure. Major health organizations discourage routine imaging unless red flags are present. The chiropractic vertebral subluxation concept lacks scientific support, making x-ray justification for treatment questionable. And clinicians should prioritize evidence-based care, functional assessments, and ethical imaging practices when needed, not on a whim, because that's how you were taught at chiropractic college. We'll end it there. Luke, any last thoughts?
That was a good episode, man. A lot of information in that, so I'm happy.
And Giles?
Go read the research. Listen to this. Go and read the research. Make up your own mind. Just critically think.
Yeah, read the research. It'll be in the show notes. Download it. Take your time. Make your own notes. Think about it. Talk to your colleagues about it. Talk to your friends about it. This is really important information and content, and it's definitely something that we want to get out there more, because I feel like a lot of people are unaware of it or unaware that chiropractors are doing it. And I just want to say there are so many fantastic chiropractors out there that don't do this, of course. There are so many modern chiropractors out there that are doing fantastic evidence-based care, that have fantastic clinical rationale, and they're not doing this. So we're not lumping them all together, but there is still a subset of old school chiropractors doing this routinely, and that is an issue. Anyway, thanks for listening to the podcast. Be sure to check it out on Spotify, Apple Podcasts, and if you want to watch it on YouTube, otherwise check the clips out on Instagram, OMT Training and the Rehab Professionals. Thank you once again. Have a fantastic day, and we will see you next week.
See you later.
Amen.
Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast.